Welcome to the Jerry Pal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who is our guest today?
Today we have Anna Chodos, who is assistant professor in the Department of Medicine and Division of Geriatrics here at UCSF. Welcome to the Jerry Pal podcast, Anna.
Thank you for having me.
Before we start off every podcast, we asked our special guest to give Alex a song to sing. What song is it today?
It's Operator by Jim Croce. It's an oldie but goodie.
And I heard you're going to sing too?
Yes.
Okay.
All right. Isn't that the way they say it goes? But let's forget all that and give me the number if you can find it, so I can call just to tell them I'm fine and to show I've overcome the blow. I've learned to take it well. I only wish my words could just convince myself that it wasn't real, but that's not the way it feels.
So Anna, we invited you to come on today to talk a little bit about what you're doing with something called the GWEP. Many of our listeners probably have never heard of that before.
GWEP?
GWEP? How do you pronounce it?
There is a linguistic divide in this country, but some are GWEPers, some are GWEPers.
Yeah,
It's
pretty polarized?
It gets a little heated.
Okay.
The last national conference was a little rough. But
So what is the GWEP?
So we are a faction of this country brought together by a funding opportunity at HRSA to fund geriatricizing primary care and social services in this country to better serve older people. I think many of us may be more familiar with the idea of big G, little g geriatrics, and this is really trying to hit hard on the little g geriatrics of getting geriatrics knowledge and skills into more people in the healthcare workforce, and in this case also the social service workforce, without necessarily only focusing on developing big G academic geriatrics or specialty geriatrics.
And what you're doing is you're doing both. So you're doing teaching here at the academic university, but what's really interesting is you're also bringing this out into the community and working with a lot of community partners to deliver primary geriatrics and primary palliative care teaching to them. Is that right?
Yes, and other GWEPers will feel similarly that the call for this funding really incentivized people to do that, to be creative, to do integration between healthcare and community. And everybody's has looked different. There are 44 across the country. So many states have them, many cities have them. But it really incentivizes us to create reasons to work together, reasons to improve care for older people across those two service areas for older people. And the way it looked in our world, and I think probably that, I've not been here that long, but what I understand is that a lot of us have been working with community partners for a long time to try to improve care for older people or get more services for older people. I mean, that's just such a part of what we do and how we keep older people healthy and well in the community, that there was a lot already there to build on. But the really wonderful thing about this particular program now is that that's what we're supposed to be doing, is working together, meeting regularly, having shared goals, having shared vision and outcomes around improving care for older people. So we work with Alzheimer's Association. We work with other nonprofits like here in San Francisco, Open House, which serves and runs programs and does housing for older people who identify as LGBTQ. We work with Homebridge, which is a training organization for caregivers, usually funded by in-home supportive services. And we work very closely with probably the biggest partner, which is Department of Aging and Adult Services, which is our AAA here in San Francisco, or, the way most of our social services are coordinated for older people, especially low income and vulnerable. The reason some of those partners are part of this particular program is the people we serve. So here in San Francisco, we're really wanted to make sure that any programming we were doing and any girding of our system and safety net for older people was going to address the people that we have here. And that's largely immigrant. Over half are 3 times the federal poverty level or below, which here is significant because it's a very high cost of living area. Of course, a very notable and proud LGBTQ community. We also have about 30% of older adults who live alone. And then a big call within all the GWEPs was to try to focus on adults with dementia and related diseases. So we've done that as well. But that's certainly a natural focus for us. We know that those are vulnerable older people. So hence partnerships with Alzheimer's Association, DOS, and Open House.
What do these partnerships actually look like? What does it mean to partner with someone?
Yeah. A lot of exciting emails. No. I mean, really, it means meeting. It means going to their organizations. It means talking openly about how can we both do things that will, advance our shared goals? Should we look for funding together? I mean, like working together.
Could you give an example?
Yes. And then the other thing is of course, we do a lot of trainings together. So we actually work on developing the bread and butter of what we're doing and trying to build competency in working with older people is knowledge transfer, teaching. We can probably end up talking a lot about whether or not that's the right, that's the only thing you need to do. But that's where we're starting for the most part. And so we're working a lot with Alzheimer's Association and us to train another partner organization. Sorry, we actually have so many that sometimes I forget to list them all. Little Brothers Friends of the Elderly, which is an international or at least national organization that is a volunteer visiting program for isolated seniors. And with them, Alzheimer's Association and us, we sort of take turns and collaborate on training on topics specifically more related to dementia and helping them work through a program that they're developing to address the needs of older adults living alone with dementia, because that has previously been challenging, especially when people don't have the skills or feel intimidated, as it were, by working with older people with dementia. And they know that's a highly vulnerable group. So they were really invested in learning more about dementia and how to work with people with dementia and develop a program within their own organization of being able to do more outreach to them. They have a name for this program, Elder Navigator. They're working with other faculty at UCSF. So it's a big program with a lot of tentacles, and we get in the mix and help do some of the education and competency and self-efficacy building around working with older adults so that ultimately those older adults will get more connected.
Yeah. So there's a lot of talk in geriatrics and in palliative care about doing primary geriatrics or palliative care, which is often teaching primary care doctors and frontline healthcare professionals about how to deliver either one of those topics.
Although I think there is a distinction there in that when we talk about primary palliative care, it's usually like the primary care physicians or the oncologists. Or it's still a layer of, for the most part, physician specialists.
Yes.
Who
and
are
not
training.
Community providers.
And not community providers. So this is somewhat distinct. This is almost a different level. It's like there's tertiary, secondary, primary palliative care, and then very like, what is zero?
Or maybe it goes to quaternary, like it's the top level. It's the thing level that all of us should be trying to achieve or strive for, is actually getting it out of just this ivory tower, the physician's office, and into community partners, because they're the ones delivering the most amount of care.
Well, the thing that we've heard a lot and is, to me, totally at once sort of mind-blowing and inspiring is the people who are absolutely on the front lines. Like, so in our community, we have a bunch of, aging and disability resource centers. And these are meant to be little community hubs that people can walk in and get hooked up to resources or learn about stuff, not necessarily get enrolled and do a bunch of paperwork, but just get some information. And a lot of the absolutely frontline people feel like they need more help knowing how to work with older people. Just the basics. Like, how do I talk to somebody who constantly comes in and tells me she's worried that, they're poisoning her water? Like, what am I supposed to do about that? Who am I supposed to connect with? How should I be responding? So even...
Oh, can I ask a question?
Yeah.
How should they be responding?
By lots of bottled water. And no, I mean, one thing is you need to know what the community mental health resources are. You need to be able to respond affectively and not necessarily to the content of delusion. I mean, I know there's some skill there, but understanding that the person, if they weren't doing that the week before, might actually be ill, and reaching out to others to see, hey, maybe you should go see your doctor. Where is your doctor? But just like the basics of what's dementia and how is that different than normal aging? It's not normal aging. Some of these like pretty basic concepts. How might a mental health disorder look differently? And then again, like we're all constantly learning about new resources from each other in the partnership through meetings, through having discussions about new training needs that we've identified because we did a training and somebody came to us saying, oh, we'd love another training in XYZ, talking to partners and then finding out, oh, there's this other organization that works on training people on pulse forms or advanced directives. So it's actually been really humbling to realize as a provider, I do general primary care and geriatrics. I often feel alone, like why aren't I getting this person connected to services? Or even our social workers who I work with constantly are having trouble. And then I talked to some of our partners and realized there was 10 other things we could have tried to connect that person to. And so I've realized we actually are in particularly here in San Francisco, a resource-rich place. That's not necessarily our problem, but the connections aren't happening. And sometimes some people aren't recognizing things like maybe elder abuse or self-neglect or early dementia and aren't connecting people early enough or, helping out enough to, because a lot of times people will hand you a pamphlet and say, call this place to get a caregiver and there's a misconnection and nobody ever figures out why. And it's because they have undetected cognitive impairment or whatever it is. So I know I'm saying a lot of words, but I think generally the thing we're learning is that people want to serve older people really competently, really well, of course. I mean, everybody who's gone into a social service field or a healthcare field has pride in the work that they do and want to be doing a good job. But there's a lot of missed opportunity with older people, not knowing what you don't know about very common things that affect older people and how you could connect them. So it is less glamorous than, richly physiologically describing or medically describing a geriatric syndrome. But a lot of this basics and social service resources is like extremely helpful. And we get a lot of great feedback from people when we're able to train them. And
we're probably not alone in that we live in a city where there are these resources, but many of us, including myself, may not know what they all are. Do you have any hints or tips or tricks or lessons that you've learned over the course of the last couple of years on how we can build those connections? I
think one is, and we're certainly doing this now, is a bit of inventory. So, spending some time learning what's out there. I think some cities have done a better job in terms of creating usable central resources. And I know that that's in motion, and that's by no means our work, but encouraging like social workers. So a lot of places aren't going to have geriatric social workers. We don't. So encouraging them to learn a little bit more about key issues with older adults, and that would be particularly caregiver services and sort of eligibility. So things to keep them independent in the community, because that's what matters to older people, or adult day health programs, and long-term care issues. So that comes up a lot, and you'll often get people saying, okay, well, it's time. We were thinking this weekend we would, put her somewhere where she can be cared for better than we can care for her. And you're like, well, that's going to take maybe 6 more months. But encouraging people to learn. I mean, I think people have to know what they don't know and know that they need to ask and learn. And so, of course, we like to show up and offer to do some teaching too and leave behind some resources.
Yeah, some would say, what are you, a doctor, doing this? Why isn't this the domain of social work? What's your response to that?
I think it's, for most of us in geriatrics, we know that the social determinants of health are half of the battle in terms of keeping people well and having a high quality of life. So I don't think we can shut that out. I also think it means a lot and sometimes takes a lot to get to a place where some of these big resources are needed. So let's talk about what another living arrangement might look like, or let's talk about what taking away driving responsibility might look like. And I don't think, I agree. First of all, none of us have time to do all the things we're supposed to be doing in primary care. We all know that. So to add on, I'm going to counsel you now on caregiver educational strategies for dealing with dementia behaviors, which at the end of the day is the most important thing you could do for that person and that family if there's dementia behaviors, is just not feasible and practical. But if you don't even know where to start, you're definitely missing an opportunity. So I think you need to have at least a passing knowledge of some of these things, because it is the biggest issue facing that family and that patient. And the biggest thing you could do for that person's well-being is probably to address some of that stuff.
But really, why a doctor?
Well, I'll give you an example. So when I went to, not from my work, but from my personal life, when I went to my follow-up with my primary care physician, I followed up diligently for something that was no longer a problem. So I basically sat down and told her that. And she was like, okay, well, I guess we're done. And I agreed. She said, so we have about 15 minutes. Could I ask you some questions? And we literally reviewed 2 cases that she had coming up that afternoon of 90-year-olds that she didn't know how to address. Not medical stuff, of course, social stuff. So one, she wanted to talk about driving. Another one, she wanted to talk about safety at home. And this is why she's she has 30 years of primary care experience on me, but this is the issue most affecting the care and well-being of her. Well, maybe not most, but my assumption, but clearly affecting the well-being of her patients, and she doesn't know how to manage it. So that's why I feel like the little G geriatrics, getting that into primary care, is definitely important. And for us, that does include the social stuff for sure.
It's interesting. So we've got, in palliative care, we have primary, secondary, and tertiary. And in geriatrics, we have big G, little g.
Yeah, it's a little simplified.
That's great. The big G geriatrics being like the academic geriatrics.
I guess big P, little p does not sound.
Oh, yeah.
It doesn't. No, but here's the other. We're talking about, is it GWEP or GWEP? All right, is it palliative or palliative?
Ooh.
I think the key there is, if you're from the United States, it's palliative, and if you're from Canada, it's palliative.
Like a pail?
Like a pail. But I don't think that's a hard and fast rule.
Yeah, maybe we should change this podcast to Jerry Pail.
That's what we should do.
For all you Canadians out there,
Welcome to the Jerry Pail podcast.
Jerry Pail podcast.
So, and I have a question
Yes.
for you. You're getting funding to do this through the GWEP.
Yes.
So what can you say to our listeners out there who are not getting funding to do this through GWEP?
Aside from get funding.
Right. Aside from get funding, what would you say to those listeners?
Yeah, and I'd also say that is the generous and wonderful nature of this project, is that it has allowed for that, because I know historically that has not been the case, and probably a lot of the reason why some of this work wasn't done before, because it's not like people didn't know it needed to be done or weren't hoping to get it done. One thing actually I'd recommend is all of the GWEPs have, like most of us have great websites. Okay, we're still working on ours, www.optimizingaging.org.
Ooh, I like that.
Thank you.
Do you know that you don't have to say that www anymore? Like that. I'm still doing that, but the young kids, they don't do that anymore.
No, they just say http / /
Right.
They're more completists.
Okay, so optimizingaging.org.
Yeah,
Put a link to that
optimizingaging.org.
below. Yep.
So a lot of us have great material. Modules like videos, handouts, ways to educate yourself. I mean, I think there's still an element of knowledge transfer that needs to happen. And then the other thing about the GWEPs that's been really interesting is they encourage what they call rapid cycle quality improvement methodology to the work. So in the areas where we are contributing to systems change to help formalize some of the knowledge and improved little g activities, we, sort of try to rapidly both implement, a change, study it, and improve it. So there's a lot of materials around like how to do a screening in your clinic, how to incorporate, a quick fall screen, and then incorporate like a nurse, sort of nurse specialist in geriatrics to manage falls and or, positive cognitive screens, things like that. And already in our, 2 years, so limited experience, working with 3 different primary care settings, and within that, very different clinics. Everybody's approach is different, right? So there's no one solution for a primary care clinic because they're all so different. They all have different patient populations and they all have different workflows. And so this is where potentially it gets a little dry for people to think about, but that's where the rubber meets the road. How are you going to screen for cognitive impairment and who, and how are you going to track that? And then how are you going to follow up on that? What does that look like? And that's another big part of what we do. So I think a lot of the GWEPs have a lot of those materials online. And that's like actually the focus of our last year is to develop train the trainer materials so that we can expand our reach a little bit and empower organizations and primary care settings to train somebody within and have materials, and then to really beef up our website and materials that people can use. So all of this is the federal government funded us to do it. So we want people to have it.
I want to back up a sec. Did you say we should be screening for cognitive impairment in primary care?
I did not say that.
Okay.
However, some places want to do it, and I salute them because I think it's a wonderful idea. I will say that is actually one of our projects is not working with primary care, working with the community. So our Department of Aging and Adult Services in their in-home supportive services division, which is the caregiver division, so you have to have a functional impairment to get a caregiver, is going to be screening everybody for cognitive impairment. So one of our parts of our program was to help work with that idea and figure out how you could do that, how you could get that information, through their system appropriately and have appropriate quality control and, further evaluation as needed within their own organization, and then feed that back to primary care, which is their goal. So they know, they felt really strongly that they wanted to see this better addressed. And I think it's amazing because that's really going to, if we can reach those primary care doctors, which is part of our role to help them think through that and hopefully do it well, how are they going to respond to that information?
Has that rolled out yet?
No, it's rolling out at the beginning of the next calendar year. But it's pretty amazing, especially considering they have 22,000 clients.
Wow.
So it's really
Aging and adult services.
in the in-home supportive services. Yeah.
22,000 clients.
And all 22,000 will have cognitive screening.
That's kind of the idea. Like they have a regular intake. However, obviously, I learned that you're not supposed to screen people who already have something. So things like that, we won't need to screen people.
Right. Yeah, if they already have dementia, then there's no
presumably.
Screen, right?
Although it's not, but the whole point is probably a lot of those people are undiagnosed.
Right. And that's probably a better target population where screening might make sense rather than a general primary care population. Because aging and adult services sees people who are highly likely to have cognitive impairment. But then the other tricky thing is there something you can do about it? Like, what will the primary care doctor, once they know their patient has cognitive impairment, what will they do? How will that influence them? And then can you give them what should they do?
Well, so then the thing I hear from primary care is we don't have anywhere to send them. We don't have time to do an evaluation. We can't do anything about cognitive impairment anyway. So it depends on the setting. For some of them, we have developed here's how you work up cognitive impairment in our system. So not a theoretical up-to-date article, but in here's who you might click on this button to order this lab, like a very specific algorithm. Here's who you might refer. And then someone like me is very interested in using that information to advocate for more resources to address cognitive impairment and make as comprehensive as we can care plan. Because I personally don't agree that you can't do anything about it.
Are there one or two most salient lessons that you've learned over the course of the last 2 years of bringing little G out there in the community?
Yes. In our short time, we have had a tremendous experience. First of all, realizing how grateful people are for some knowledge addressing these topics that they're really underaddressed, and how eager people are to be incredibly competent and good at what they do. So it's really well received. And we have definitely almost at every point identified more need. So I think we certainly have that feeling, who knows how far it will go, but of a tip of the iceberg kind of feeling of the need for this kind of knowledge and competency building. And then the other lesson clearly for us has been sort of the joys of partnering with people who are so committed to making sure older people have joy and dignity in their lives, no matter where they are, no matter who they are, no matter what resources they have. And so working with all of our amazing partners like Little Brothers, Homebridge, DAS, UC Hastings that help us do medical legal practice work, Alzheimer's Association, of course, social work schools, our nursing schools here. Like, so on the academic side, everybody. And from the partnership side, we are just starting to evaluate that and asking people. They say that even in a field that they've worked for a really long time, the fact that we're all partnering together in this effort has opened more doors for them. And I think I'm more and more convinced that there really isn't enough resources to build the big G, and that the little G is very much worth our time.
So what's next for GWEP?
Well, we have some big hills, not unknown to us here in beautiful San Francisco, but the big hills are obviously how sustainable and how real is federal funding going to be for this sort of thing. So we are obviously carefully watching and advocating for ongoing funding for stuff like this. But for us, really, personally, as a program, our next is how far out should we be going? So if you look at other societies, communities that have other values and other sort of organizational structures, Japan, Singapore, even frankly, places like Utah, where there's this tight social structure, there's a lot more lay people involved in detecting and addressing issues with older people. And their idea of what you need to be a competent society to, again, bring joy and dignity to the lives of older people in their everyday is bank tellers need to know what's going on because they make mistakes at the bank. Wow. Post office guys need to know what's going on because they're the ones who actually see older, isolated people. So there's a lot of amazing lessons to be learned there. And I'm certainly passionate about that kind of work, and how much I convince people who fund academic geriatricians to be doing that kind of stuff is really fascinating to us. And you guys think about the primary, secondary, tertiary, and I think we think of more of a nesting dolls, concept of how many rings out are we going to go in touching our community, making sure they're competent. And probably the farthest out we've gone, and in collaborating with Bree Williams and her amazing work, is with our police department here in the city, because they respond to a lot of crises with older people and making sure they know that there's certain considerations like behavioral disturbance and dementia that aren't criminal activity. So, working with them in the context of a crisis intervention course and doing trainings, that was something that Bree Williams started, who's very involved in criminal justice. So that's as far out as we've gone, other than we do like I just came from a talk at a community center with older people, just talking with an older women's health group. And, so that's obviously really important too, to empower people and their caregivers and family. But we'd love to think really broadly and build more partnerships.
So how about we end with a little bit more of the song?
Operator, what could you help me place this call? See, the number on the matchbook is old and faded. She's living in LA with my best old ex-friend Ray. Gosh, she said she knew well and sometimes hated. But isn't that the way they say it goes? Well, let's forget all that and give me the number if you can find it, so I can call just to tell them I'm fine and to show I've overcome the blow. I've learned to take it well. I only wish my words could just convince myself that it just wasn't real. But that's not the way it feels.